the importance of having a national guidelines. And that's, again, said when we are talking about the dyslipidemia management among the Saudi population. First of all, I want to take this opportunity to really thank the great team of experts who worked with us in these guidelines and dedicated their times and effort to start the first version of the Saudi dyslipidemia guidelines. It was a marvelous work with a lot of dedication and efforts over a 3-month period to come up with a version that's easy to use and deliver the important key messages on our guidelines. So can I move to the next slide? Can we move to the next slide? معلق عندي. Next slide, please. Okay, so the main objective, I think we all understand that a nationwide evidence-based policy and guidelines to implement a unified approach for the management of dyslipidemia is highly needed. And for that, the Saudi clinical practice guidelines will provide the recommendation applicable to the Saudi patient who are at risk of developing these cardiovascular diseases. Of course, these came from 2 important identified issues that contribute to the high burden of dyslipidemia in Saudi Arabia. We all know that the disease burden is underdiagnosed. More than 65% of Saudis with dyslipidemia are underdiagnosed or unaware. And this was in 2013 data that was published. And also we know that the disease management is still an issue, and we have also a high percentage of patients who are under treatment. Now, the methodology of these guidelines, similar to the other Saudi guidelines methodology that has been used. So we use a class of recommendation and a level of evidence that is based on the references, as we can see here. And in the Saudi guidelines, we basically reviewed more than 144 literatures to overcome this class of recommendation and to provide the level of evidence. We found that the European Society of Cardiology guidelines recommendation characterized and target a cutoff which was the main guide while developing our Saudi guidelines. Why? It strongly believed that the tighter control that was imposed in the European guidelines is the most appropriate to be implemented among our Saudi population, given the burden of the disease in our community. So the key insights that I want to come up with the Saudi guidelines and try to summarize it to our audience, which hopefully will stimulate everyone to go and read it in depth. 1, we give a full description on the pharmacological intervention and the approved indicators as per the Saudi FDA, and that's why certain medication was included if they are approved by the Saudi FDA. And also we give an insights on the gaps in the cares and the strategies that we need to encounter in order to encourage the adoption of preventive measures, which is still need to be well identified. So the recommendation for the cardiovascular disease, we started with the risk estimation in Saudi Arabia, and we all know that the risk score in Saudi population is not developed yet. For that, we are using the score system, which is recommended. However, it's not being validated. We will consider as a class 1 recommendation, giving the importance of this in the other important guidelines, but developing a new risk calculator is also recommended. And this is was one of the recommendations that we added in our guidelines. We also focused on the lipid analysis in the Saudi population and looking at the lipid panels that need to be included. We understand that most of the patients come to our clinics will require to have a lipid panel done. One of the major factors that will challenge the test is the patient is not fasting. So non-fasting random lipid sampling may be used for screening purpose, and this was added to the guidelines and give a level of recommendation to be based on available references. The one thing more also we added in the guidelines, now we understand the treatment goal across the cardiovascular risk categories, and it has been explained in the guidelines, reaching a low, moderate, high, and very high group, but we focus very well on the extreme high-risk group who has recurrent events. And this was basically in the European paper that was published after the guidelines of the European groups, and it highlighted on a tight control of the LDL in patients who have recurrent events under the description of extremely high-risk group. So this was one of the parameters that was added. We tried to make a very clear line of the target goal of LDL, non-HDL, and ApoB in these risk category groups. We also focused on the very common categories of diseases that we face, the management of dyslipidemia as a cornerstone in their therapy as the acute coronary syndrome. And we understand that a patient usually is recommended to start on a statin, but here again, we are emphasizing on class 1 recommendation to have a combination therapy with ezetimibe or PCSK9 inhibitors, irrespective of the baseline LDL. And again, looking at that extreme high-risk group, or a patient who have recurrent attacks, and adding a triple therapy as a class of recommendation of 2A to this particular group of patients is also highly recommended in these guidelines. So combination therapy, secondary prevention, and triple therapy in the extreme high-risk group is something that we really had to highlight it in our guidelines. We also touch base on other group of patients like diabetes and chronic kidney disease and familial hyperdyslipidemia, and we can go over the details and the class of recommendation of their management, which was hopefully easily listed in our guidelines. Now, just to come up in the last 40 seconds with a very concise, comprehensive solution to encourage the adaptation of the preventive measures in Saudi Arabia. And we think that having a standard policy, establishing a lipid clinic, a unified record for our patient, the awareness and the use of the social media will definitely gonna help. We had a very nice, easy clinical pathway established by the experts who wrote these guidelines, who can help either in the inpatient settings or the outpatient setting to drive the management of these patients. So the final document that has been, and I'm very happy to mention that, approved for publication and will be released in the coming issue of the HeartView Journal. We tried as an author for these guidelines to present the following recommendation. Can I have the last slide again? Excuse me. Can I have the last slide? بس آخر slide. So as you can see, there are recommendations and guidance for details risk assessment. We have the position of a newer cholesterol-lowering drugs within the management algorithm. We updated the patient treatment option in primary and secondary prevention. We highlighted on the special attention we need to our patient subgroup with a comprehensive solution to encourage the adaptive preventive measures and the clinical pathway that will hopefully help the practitioner from different specialty who deal with dyslipidemia patient make their management and reaching the goal of therapy more easable and achievable. With that, I thank my group again, and thank you, Dr. Adel.